Internal radiation therapy, or brachytherapy, continues to be a viable treatment option for prostate cancer. You may be wondering, how does this work in treating prostate cancer? Would I be a candidate for this sort of therapy? Are there any new advances with brachytherapy that I should be aware of? Well, I have a special guest here with us today who is a radiation oncologist and prostate cancer expert who will have the answers for us. So stick around. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On a weekly basis, we will be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pullman, and welcome to the Prostate Health Podcast. Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. Prostate Health Podcast listeners, you will be excited for our interview today with internationally renowned radiation oncologist and prostate cancer expert, Dr. Ronald Chen. Dr. Chen is currently the Department Chair of Radiation Oncology at the University of Kansas Medical Center. He has helped write many of the national standards and guidelines on the treatment of prostate cancer and lectures across the U.S. and internationally on the treatment of prostate cancer. His research interests involve the long-term outcomes of prostate cancer patients and survivors. This includes the effectiveness and long-term quality of life effects of different treatments for prostate cancer. He completed his residency training at the Harvard Radiation Oncology Program in Boston, then served on the faculty at the University of North Carolina at Chapel Hill, before becoming the Chair of Radiation Oncology at KU in 2019. Dr. Chen, welcome to the Prostate Health Podcast.
Thank you very much. Happy to be here.
So back in episode 10 with Dr. James Yu, not only did we cover some of the basics about how radiation therapy works in treating prostate cancer, but also quite a bit in terms of focusing on external beam radiation therapy for prostate cancer in that episode. So today, I thought we would really help out our listeners with a discussion on internal radiation therapy or brachytherapy. So Dr. Chen, for our listeners, what is brachytherapy?
Yeah, so thank you very much. So I think most people are familiar with external beam radiation. So external beam radiation is where the patient gets treatment from a machine, and the machine will focus X-ray radiation at a particular target, prostate or breast or lung, for example. And that beam of radiation from the machine has to pass through certain parts of the body, certain tissues or organs to get to the target. And so that's external beam radiation. I think most people are familiar with that. Brachytherapy, as you said, is internal radiation. And so it usually requires a procedure where we would actually be able to put the radiation directly to the target. So for prostate cancer, for example, it's a procedure where we actually put little radiation pellets or radiation seeds directly into the prostate, and then the radiation seeds then release radiation exactly from within. And it's a way to deliver radiation directly to a tumor without having to go through other organs like external beam radiation. It's not new. Both external beam and brachytherapy have been around for decades and have been used to treat prostate cancer for decades. And there's different patients that need different types of radiation.
And how does it work in treating prostate cancer?
Yeah. So external beam and brachytherapy is really just two different ways to deliver radiation to a particular target. So they work pretty much very similarly. Radiation kills cancer cells by damaging the DNA of the cell. So then it's basically not able to divide, and basically then the cells is able to die because of damaged DNA. So brachytherapy does that, and so does external beam radiation.
So what are some of the benefits that you would list for brachytherapy?
Yeah, and brachytherapy is, we can only use it when there is a tumor that is accessible with a procedure. So prostate cancer is accessible, and there's other examples where in gynecologic cancer and breast cancer, those are some of the cancers where we can actually reach. And when we could do that, we can deliver the radiation directly to the target. And that's really where the benefit is. The benefit is potentially, if the radiation doesn't have to go through other organs to reach where we need to go, it can potentially reduce side effects. But in prostate cancer specifically, it can actually potentially cure more patients. And I'll just give an example. So in prostate cancer, with external beam radiation, we are limited to be able to only give about 75, 80 gray in terms of dose with external beam radiation to the prostate, because beyond about 80 gray, we risk damaging bladder and rectum and bones and some of the other organs it has to go through to get. So with external beam radiation for prostate cancer, we can't give as much as we like, or we're limited by how much we're able to give. With brachytherapy, when we put the radiation directly into the prostate without going through organs, we could actually give twice the amount of dose to the tumor with brachytherapy. And so if we're able to treat the tumor with a higher dose, actually there's many clinical studies now that shows that it can actually cure more patients with prostate cancer.
Wow. Oh, that's great. And now from a technical standpoint, we kind of briefly discussed this just kind of in the initial description of brachytherapy. But again, how are the implants technically placed in the prostate?
Yeah, brachytherapy there's different ways to do it, but the way that I've been able to do it for the past 10 years or so, it's really just a one-time procedure. And it's under anesthesia, just for patient's comfort. And it takes about an hour and a half to 2 hours. So it's a one-time hour and a half to 2 hour procedure under anesthesia. And I describe it to patients that brachytherapy is a little bit similar to a prostate biopsy. The way we actually do the procedure, the way we put the seeds in the prostate is with needles. And an average case probably takes about 15 needles or so, which is very not too dissimilar from a prostate biopsy. The two differences are, one, it's under anesthesia, and so a little bit more comfort there, but also the patient doesn't move when the radiation is being put in the prostate. And two, the needles are placed not transrectally, but actually transperineally. And so that also cuts down on the infection risk. So a one-time procedure, an hour and a half to 2 hours, roughly 15 needles or so to put the seeds in the prostate. And then basically that's the treatment. And the patient actually also goes home on the same day without staying in the hospital.
That's great. Now, for patients, how do you map out kind of where these implants or these brachytherapy seeds go?
Yeah. So for almost all the patients with newly diagnosed prostate cancer, the current standard treatment is still to treat the entire prostate. So with prostatectomy, for example, usually the urologist will remove the whole prostate. With radiation, we usually treat the entire prostate. And with brachytherapy, basically, we also put seeds so that the entire prostate gets treatment, just like surgery, just like external beam radiation. The thing that we do is we actually have to calculate the size of the prostate to then be able to determine how many seeds need to be placed. So obviously, I think a bigger prostate will require more seeds to give it adequate treatment, and a smaller prostate doesn't need as many seeds. When I do the procedure, I do look at the biopsy results, so where in the prostate there's more aggressive cancer. I also look at the MRI if there is one to see where the pyrite 5 lesions are. And in those areas, I probably will focus a little bit more of the seeds just to make sure if it's more aggressive cancer, we treat it more aggressively. But the general idea is that we do treat the entire prostate, and the number of seeds is based on the size of the prostate. There actually is another potential benefit for brachytherapy. I think historically, and I still hear this from patients, sometimes people say, well, if you have radiation to treat your prostate and the cancer comes back, you don't have any other options. But actually, we can actually use brachytherapy to treat recurrences in the prostate as well. And so if a patient has had prior radiation and now has a recurrence, we can use biopsy results and MRI to locate where the recurrence is and actually be able to do brachytherapy for part of the prostate. That works really well. That's another way we do brachytherapy for these patients.
Well, thanks for sharing that. Now, some questions that I get regarding brachytherapy is this a permanent implant? How long will this implant stay in the prostate, and how long will the implants remain active inside of me?
Yeah. So a lot of people do the permanent implant, and that's what I do as well. And so with a one-time procedure, we put the seeds into the prostate, and that's it. There's no other procedure to treat the seeds afterwards. And so there's no second procedure. And so the implants, the seeds do stay in the prostate. In terms of how long they work for, I usually sort of make the analogy like batteries. And so the seeds that we put in are programmed to give a specific amount of dose. and then it wears off over time. It's like a slow release battery. And so the seeds get weaker every day that goes on. And then the strength and the intensity of the treatment also decreases over time. The most commonly used seeds for this procedure is iodine 125, and that's what I use. That's what most people use. There's a couple other options, but with iodine 125, the half-life of the seeds is 2 months, which means every 2 months, the seeds become 50% active. And so it decays over time. It gets weaker over time, sort of on a 2 month to 2 month basis. And so that's what I usually tell patients.
Now, are there any precautions that they need to be aware about kind of during that course where the seeds are still active as far as, staying away from children and so forth?
Yeah, that's a very common question. The fact that we are putting radiation inside the patient's prostate, does that make that patient a little bit radioactive? What I usually describe to patients is that the radiation does not travel very far from the prostate. And so, in fact, the patient is safe to the public. If they weren't safe to the public, we wouldn't release them to home on the same day. And so they're safe to the public. They don't have to worry about going to church or going to a restaurant or be around their family. They're really safe to the public in terms of radiation. There is precaution we give them in terms of a small child and pregnant women. In general, we would say no pregnant women within 3 feet, which not a long distance, but about 3 feet, no pregnant women. And we would advise no small child sitting on the lap of the patient for 2 months after the procedure. But just to put that in perspective, the reason for the lap is because that's actually the closest place where the radiation, the seeds are. And so, but if a child were to accidentally sit on somebody's lap, they would have to sit on the lap continuously for many, many, many hours to get exposure equivalent to an X-ray. And so just to be extremely cautious, we say no child in the lab for 2 months, but really I think the exposure is very, very little.
Yeah.
One more thing I've done probably close to 1,000 of these procedures, and patients ask, I don't want any exposure to anybody. What can I do? I've had maybe a couple of patients purchase lead underwear to wear to completely block the radiation. It's not a very common thing that patients decide to do, but that is available if people are really worried about that.
Yeah, well, it's nice to know about that option for those ones that are a little bit more anxious about that. So, and when we talk about the different types of brachytherapy, I think, kind of the standard or, kind of the more common one that we were talking about is the low dose, but I was going to see, I thought it'd be helpful just to maybe kind of go through what is the difference between low dose brachytherapy and high dose rate brachytherapy?
Yeah, that's a really good question. And so I think certainly a lot of patients and physicians who are not radiation oncologists would not know the difference, but you hear different options online. And the really key thing that you said is the difference between a low dose rate and a high dose rate brachytherapy. The word rate is important because low dose rate does not mean the patient is getting a low dose of radiation. In fact, they're getting a good dose of radiation, but the rate means that it's released slowly over time. And the high dose rate, it doesn't mean they're getting a high dose of radiation. It's just that the rate is faster, it's delivered a little bit faster. And so the practical difference for the patient is that for low dose rate brachytherapy, it's a one-time procedure. We put the seeds in, we let the seeds release the radiation slowly over time, and that's the entire procedure. With high dose rate radiation, the way it works is that the patient will have a procedure, but instead of putting seeds in the prostate, the physician actually puts little tubes or channels that sticks from the prostate to outside of the patient's body. And then with those channels, after the procedure, you then hook up those channels to a machine that will then feed the seeds through the channel into the prostate for, 10, 20 minutes. And then the seeds give treatment during that time. And then the machine actually takes the seeds back. And so it's not permanent seeds in the prostate. In fact, you have channels and you're able to feed seeds in and out of the prostate for treatment. And so then there's no seed left in the prostate. And so that's sort of the difference. The other practical difference for the patient is that sometimes for high dose rate radiation, you may require multiple procedures instead of one because you may have to have multiple treatments. And sometimes patients have to stay in the hospital. So maybe on day one, you have the procedure, you have your first treatment, then those channels and catheters stay in the body overnight. And then the next morning, you get your second treatment. So sometimes a hospitalization is required as well. So maybe multiple treatments, maybe multiple procedures. In general, the radiation oncologists believe that low dose rate and high dose rate work about the same in terms of curing the cancer and work about the same in terms of side effects, but they're just two different ways of delivering radiation to the prostate.
Well, I think that's an excellent explanation there. Thank you for that. And now, when we talk about brachytherapy, who would you consider as a good candidate for brachytherapy, or maybe not a good candidate?
Yeah. So I'm sure on your program, you've talked about different risk groups for prostate cancer. Yep. So Gleason 6 is often considered low risk, Gleason 7 often intermediate risk, and the aggressive cancers are high risk, Gleason 8 to 10. Just to use that framework, brachytherapy is actually a good option or an available option for all risk groups of cancer, low, intermediate, and high. For low and intermediate risk cancers, brachytherapy alone probably would be sufficient, and it would be a one-time treatment compared to several weeks of external. So those are different options there. For high-risk cancer, which is the most aggressive kind, Gleason 8 to 10, there's actually now multiple clinical studies to show that for Gleason 8 to 10 cancer, having brachytherapy as part of the treatment will allow us to cure a lot more patients. And I think a lot of that is because we're able to give more dose to the prostate to kill the high-risk cancers in the prostate. So there's actually a randomized trial that compared external beam radiation versus external beam plus brachytherapy, and external beam plus brachytherapy led to a much higher cure rate at 9 to 10 years of follow-up. And so I think for high-risk patients, this is especially important. And also, as I said before, another good candidate for brachytherapy would be a recurrence after prior treatment. The one part where I think is not a good candidate is that sometimes for patients who have a very large prostate, I usually use 60 grams or 60 cc's as my cutoff. And so if patients have prostate that's beyond 60 cc, sometimes brachytherapy has trouble getting seeds to all the parts of the prostate to be able to give a good treatment, especially if there's a pubic arch bone interference there. Sometimes for patients with big prostates, we could use ADT to shrink the prostate to get to below 60, but 60 cc's, the size criteria is one where patients may not be a good candidate.
And just like with all treatment options for prostate cancer, including surgery, there are certain risks that we discuss with our patients. When discussing brachytherapy as an option, what are some of the more common risks or more rare risks that you discuss with those individuals?
Yeah, I think when I do a consultation with a patient and talking about the different options, usually the standard options are surgery, external beam radiation, brachytherapy. I try to make some similarities when I discuss the options. I really do think that there's a lot of similarity in terms of side effects across surgery, radiation, brachytherapy. So for example, I think all three treatments have some urinary issues. And so brachytherapy could cause urinary irritation. So sometimes patients could have burning or irritation when they urinate. There could be more urinary frequency with brachytherapy. One difference between brachytherapy and surgery is that surgery sometimes makes the urine flow faster. Brachytherapy could make the urine flow slower. And so slower urination is possible. And there's actually a small chance that the patient may have to go home with a catheter. Probably maybe about a 5 to 10% chance that patients may have to go home with a catheter if you're not able to urinate after the procedure. But 90-95% of patients do not have that issue. And some of the risks. The other thing that radiation could cause is because the rectum is close to the prostate, external radiation, brachytherapy, both potentially could irritate the rectum. So there's a small chance of causing blood in the stool, for example. But in the recent years, there's now there's a gel we can actually inject during the procedure, a little gel that actually pushes the rectum further away from the prostate, and that will really significantly reduce the rectum irritation. So we always do that with the procedure to cut down on that side effect.
Yeah, I think that's just great that we continue to have, increasing technology to help in kind of safeguarding some of these risks. And I think every year we're advancing in that regard. So that's great. Now, after treatment for prostate cancer, we're still in close monitoring of the PSA. Now, when you counsel these patients and seeing them back, what do you kind of talk about in terms of what men should expect from their PSA following brachytherapy?
Yeah. So with brachytherapy, because we're giving a higher dose and we're able to give a higher dose to the prostate and to the cancer, we often see a lower PSA result than external beam radiation. And so with brachytherapy, we actually could see PSA below 0.2 or even at undetectable levels. And with external beam radiation, we don't see that very often. And so I counsel patients that they actually could see undetectable PSA or PSA that's close to it. And that's something that we usually look for. One thing I'm sure your listeners know this, but one thing that's kind of an interesting phenomenon is that after radiation, whether external beam or brachytherapy, some patients have what we call a benign PSA bounce afterwards. So for some patients, maybe 1 in 5 or 1 in 6, the PSA actually sometimes could actually go up after treatment before coming back down. And that's a benign situation. The PSA releases, bounces up temporarily before coming back down. So I do caution patients to look for that if that happens, but not to be too concerned about it.
So what do you see as some of the future changes or advances coming down the pipeline for brachytherapy for prostate cancer?
I think for prostate cancer, what we have today is multiple proven treatment options, surgery, external beam radiation, brachytherapy, that really were able to cure a high percentage of patients. So I think we're in a very good place. I think the advances in these treatments really have to do about being more accurate and perhaps reducing the side effects of treatment over time. So for brachytherapy, for example, as MRIs get better and hopefully as we have more PET scans that can help us visualize exactly where the cancer is, I think then in the future we'll be able to do even more precise procedures to more accurately target the tumor and hopefully reduce the quality of life impact for patients. I think that's really where the advances will be in the next few years.
Well, this has really been an excellent and comprehensive review of brachytherapy for prostate cancer that I know our listeners are gaining significant value from. Dr. Chen will be sticking around here for a few additional minutes for the Prostate Health Academy to really get into more in terms of what one would expect as one prepares for the procedure, kind of walking us through the patient experience. So I'm looking forward to that. So in conclusion, Dr. Chen, any parting thoughts today for our podcast listeners?
Well, first of all, thank you very much for having this podcast to be able to get information, share good information to patients and physicians who are listening. I think my parting thought is, and I think this is something that I think all of us advise, I think for any cancer patient, prostate or other cancers, I usually encourage patients to seek a second opinion so they can hear about all the different options before making an informed decision about treatment. I think that's especially important for prostate cancer and especially important for brachytherapy because actually in many places of the country, there may not be the equipment or the experience to offer brachytherapy, even though there's a lot of advantages, especially for high-risk prostate cancer, being able to deliver more treatment to the prostate. So I think a second opinion is really important, and I advise that for patients who see me, and also I advise that to your listeners as well.
Well, we really do appreciate you taking the time to really share your expertise and knowledge regarding brachytherapy today. It's definitely been an honor having you on our podcast, so thanks again.
Thank you very much. I really appreciate it.
Thank you again for listening to the Prostate Health Podcast. We would love to have you join our podcast Facebook group at www.facebook.com/groups/Prostate Health Podcast, or just use the Facebook group search function and search for the Prostate Health Podcast and ask to join. We'll see you at the next episode.